Hi, my name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to uh, part three of this cardiology series where we're going to be talking about myocardial infarction. And if you haven't already, make sure to check out my previous video on angina pectoris. And if you're new to cardiology, it might be worth you having a look at my first video, which is an introduction to ischemic heart disease. So, without further ado, let's get straight into it. So, first of all, we can just do a recap of ischemic heart disease, looking, mainly at some definitions. So, we've got stable angina, which is sudden onset chest pain resolving with rest or GTN spray. The pain should resolve within 5 minutes, and you shouldn't have pain with rest. It's typically brought on by exertion. And then we've got acute coronary syndrome, which includes unstable angina, NSTEMI and STEMI. NSTEMI, MSTEMI and STEMI are going to be the main focuses of this tutorial today. Myocardial infarction, which is necrosis or death of the cardiac tissue, or the myocardium, the muscle layer of the heart. Let's talk about some of the do a recap of some of the symptoms a patient might present with. So they could present with chest pain, which is reported as a heaviness behind the sternum, or a crushing type pain, which can radiate to the jaw, neck, or left arm. And the pain sensation, like I've mentioned previously, is conveyed by sympathetic afferent nerves, T1 to T4, from the cardiac plexus. And the brain perceives the information as though it's coming from the T1 to T4 dermatomes, and that brings us, onto the topic of referred pain. And this happens because the nerves from the cardiac plexus and the nerves from the T1 to T4 dermatomes both synapse at the same position at the dorsal root ganglion, which is at the back of the spinal cord. And then other symptoms we have, which is diaphoresis, which is sweating. And this is essentially because there's, when someone has an MI, they have a reduced stroke volume and cardiac output. And then there's reflex activation of the sympathetic nervous system. Patients can present with dyspnea or difficulty breathing. After an MI, you can have mitral regurgitation, in which you have fluid going back up into the lungs and ending up in the lung interstitium. This fluid can compress the airways, therefore the patient has to work harder to breathe, so there's increased respiratory effort, which presents as dyspnea. Patient might also present with fainting or syncope. This is typically due to a vasovagal reflex stimulated by irritation of the vagal nerves of the cardiac plexus. The vasovagal reflex can also cause some vomiting, and then furthermore, the patient might look pale, and they can also have a low-grade fever due to the release of inflammatory cytokines into the systemic circulation. Okay. And the severity of the symptoms relate to the degree of vessel occlusion. In STEMI and NSTEMI, typically there's 100% vessel occlusion. They can present very variably, though. There's other ways in which they present. The chest pain might be atypical. It could be epigastric pain. It could be burning in nature. So they're very variable. And the way to differentiate between NSTEMI and STEMI is to look at the ECG. Because whether it's an NSTEMI or a STEMI determines the management pathway, which we're going to be talking about later in the video. And then thrombus formation, you have that in STEMI, and a thrombus, like we mentioned in previous videos, is a blood clot, which is formed at the plaque's site. So it's important we talk about some of the risk factors, and in the other videos we talked about modifiable and non-modifiable risk factors. We also need to talk about some non-traditional risk factors, where it's a list of substances which are elevated. Let's just recap the modifiable risk factors first. So dyslipidemia. So there's two different types of lipoprotein. So you can have high density lipoprotein and low density lipoprotein. So LDL, low density lipoprotein, the function is to transport lipids from the endothelium of the arterioles into the liver. If LDL is low, this isn't great, because we're going to have a buildup of fat within the arteries, and vice versa. HDL, high levels of HDL increases the availability of lipids to be deposited within the arterial walls. So that's something we don't want. High levels of free fatty acids as well is also a risk factor. And then the more obvious ones like hypertension, smoking, hyperuricemia as well. So high levels of uric acid seen in gout can precipitate an acute MI. And then non-modifiable risk factors such as advanced age, family history, and ethnicity. And then we have these non-traditional risk factors. So we can have elevated C-reactive protein, which is an acute CRP, is an acute phase protein associated with inflammation. During an MI, you have some myocardial inflammation occurring. Lipoprotein A, which normally inhibits thrombolysis. So if this is elevated, there's an increased risk of thrombosis. Fibrinogen, which leads to clot formation too. B-type natriuretic peptide. Natriuresis relates to means the excretion of sodium. And if this is elevated, it can indicate heart strain. Other risk factors such as chronic inflammatory conditions, left ventricular hypertrophy, and then an abnormal ABPI, which is an ankle brachial pressure index that can be seen in peripheral arterial disease. So this is just to basically recap the process of atherosclerosis, which can lead to an MI. So I talked about this in other videos. So you have that initial endothelial damage where you have reduced nitric oxide production, which acts as a natural vasodilator. And then we have the plaque growth and atheroma formation. And the result is these foam cells, which have a necrotic lipid core and smooth muscle cells. And the smooth muscle cells put down a thin layer of collagen just below the endothelium, which stabilizes the plaque initially. But this plaque can rupture due to the entering of inflammatory cells, proteolytic degradation, and smooth muscle apoptosis. And then the complications include thrombosis, which is blood clot formation, and hemorrhage. And it's important to note that the plaque contains high amounts of tissue factor, factor 3, which is involved in the extrinsic coagulation cascade, which becomes activated in contact with other coagulation factors, so particularly factor 7 in the extrinsic pathway, which leads to thrombus formation and vessel occlusion. These are all things we don't want to happen. So let's talk about MI in terms of some of the different types. So the main classification, so the definitions of NSTEMI and STEMI, from a clinical features perspective are very similar. But we also have this other type called a silent MI, which is myocardial ischemia in the absence of chest discomfort and other typical symptoms in diabetic patients. So in diabetic patients, this is much more common. And the reason why we don't have chest pain in these patients is because you have the autonomic diabetic neuropathy. So the high levels of glucose damage in them autonomic nerves, which normally transmit the pain signals to the brain. So in this case, the patients don't typically report pain or other symptoms, and that can make it even more insidious. Okay. And then in NSTEMI and STEMI, I mentioned this previously, there tends to be 100% stenosis in the coronary arteries, and then in silent MI, this can be variable. NSTEMI ischemia is subendocardial, STEMI is transmural. This is important when we look at the ECG features. So let's talk a little bit about the physical examination findings if a patient's had an MI. So I like to always split it into inspection, palpation, and auscultation. So on inspection, the patient might look clammy, sweaty, or pale. On palpation of the apex beat, it's likely to be faint and uncoordinated. Because of that systolic dysfunction due to the necrotic myocardium. And then a lot of the cardiovascular examination, lies with auscultation. So we might have some additional heart sounds such as S3 and S4. Might be able to hear some inspiratory crackles on auscultation of the lungs, representing that pulmonary edema. And we might also be able to hear a pansystolic murmur, heard best at the fifth intercostal space, mid-clavicular line. Okay, and there might also be some other types of murmurs, or another pansystolic murmur, but that's best heard at the third or the fourth intercostal space, and typically a complication of an MI. You can have a ventricular septal defect, but that's a complication which we're going to talk about later in the video. So essentially, why we have S3 is because there's a reduced stroke volume and cardiac output. There's left ventricular overfilling and turbulent early diastolic flow into a full left ventricle. And that's the reason why you have an S3. When you have an S4, the ventricle's non-compliant. So there's reduced diastolic compliance of the ventricle. At end diastole, the left atrium forces blood into a non-compliant left ventricle, and that produces S4. S3 can be considered normal sometimes, particularly in athletes. S4 is always pathological. It's always pathological. Then you might have some inspiratory crackles. And this is because there's reduced diastolic compliance, backflow of blood into the pulmonary vessels, and then you have a buildup of fluid in the pulmonary interstitium, and then the crackles are heard on inspiration when the alveoli open. And then this pansystolic murmur is to do with mitral regurgitation, which is because of papillary muscle rupture, and then because of the papillary muscle rupture, the valve leaflets are unsupported and you get this backflow of blood, and that's also linked to the flash, sometimes called flash pulmonary edema. Okay. So let's talk about some investigations, and the best way I like to think about the investigations is in terms of what you do based on the underlying pathophysiological process. So we have myocardial inflammation, myocardial necrosis, and tissue ischemia. And it's worth mentioning that an early sign of ischemia on the ECG can be inverted T waves. So myocardial inflammation, you get systemic spread of inflammatory cytokines, which is going to lead to an elevated C-reactive protein. Remember what we said is an acute phase protein. Migration of neutrophils and monocytes. Monocytes are essentially macrophages. They differentiate to macrophages within connective tissue. And then because of the neutrophil and monocyte migration, you're going to have an elevated white blood cell count. Let's look at the myocardial necrosis. So we need to think about the contents, what are within the cardiomyocytes. So we have the troponins. Troponins can be troponins I and T. They're raised 2 to 4 hours post-MI, and they tend to normalize within 14 days. And then we also have creatinine kinase, which rises 3 to 8 hours post-MI and normalizes within 3 days. So troponins are more sensitive and specific for myocardial necrosis. There's also another marker called myoglobin, which resolves within 24 hours. So it's if that elevates again after 24 hours, it could be a sign of reinfarction. Creatinine kinase is good for reinfarction 4 to 10 days after the initial insult, because it normalizes within 3 days. So you can use these biomarkers to build a timeline of events. Okay, and then let's look at tissue ischemia. So it can be subendocardial, which leads to ST depression. Subendocardial ischemia, like we mentioned in the previous slide, is associated with a non-ST elevation MI, or it can be transmural across all of the layers, and this leads to ST elevation, so in a STEMI. So that this is from this, this is very important. Okay, so this is some of my some other investigations, what you might consider. So we've got, yeah, like vital signs, blood pressure, very important, heart rate, could be elevated, a toxicology screen. So, and this slide's really for your own reference. So we mentioned in the angina pectoris video that there's a variant called Prinzmetal's variant, and this can be caused uh, by cocaine, because you get vasospasm of the coronary arteries impeding the blood flow, which can actually have some transient ST elevation on the ECG. You want to do some kidney function because the kidneys and the heart are very closely related. If something goes wrong with the kidneys, something goes wrong with the heart, and vice versa. I've mentioned the biomarkers already. Some LFTs if the problem's due to a coagulopathy, abnormal clotting, HbA1c, the patient's glycemic levels if they have diabetes, full blood counts, looking at the hematocrit, so the hemoglobin is it's raised in polycythemia where there's lots of red blood cells, and it's low in something such as sickle cell anemia. Lipid panel as well. We've talked about the HDL and the LDL and their roles. Homocysteine as well, and why not do some TFTs as well? That wouldn't hurt. I just want to talk a little bit about some of the features when you have an established MI, so a patient's had an MI, and some of the features what you'd see. So on the ECG, you might have the presence of they're called pathological Q waves. So pathological Q waves they tend to be deeper and wider than normal Q waves, and they can be an indication that someone's had an MI. The biomarkers, so the troponins and the CK, might have normalized. And remember to build that timeline when the patient, might have had the initial MI. On an echocardiogram, there may be evidence of coronary artery disease or abnormal ventricular contraction, and then sometimes they can even do an MRI, and there might be evidence of scarring of the myocardium. All right, so this is another good slide because it looks at differentials for troponin leak. So this can be caused by critical illness, sepsis, hypertension, preeclampsia. I'm sure you can read all these yourself, but the important one I want to mention here is anthracycline-based chemotherapy. If you see anthracyclines such as doxorubicin, I want you to remember that these are cardiotoxic. And then we have other things here such as renal impairment. Remember, the kidneys and the heart are very closely related; they rely on each other. And then we have stroke, subarachnoid hemorrhage, and seizures. So let's look at some ECG features of NSTEMI. So we're going to have some regional ST segment depression. We might have some T wave inversion or flattening, and it can also present with the features of new left bundle branch block, which I'm not going to talk about in this video. I'm going to do a separate video about bundle branch block, and really go in depth about that particular topic. One thing I will say about bundle branch block though is you might have widening of the QRS complex, because the signal heading down the conduction system takes longer to travel because of the damage to the bundle branch. Okay, and here we can see this arrow. So we're in lead 2, and we can see that we have this ST segment depression. So look at this complex, and then this one, and then the following complex. So let's talk about the features of a STEMI on the ECG. So we're going to have some ST elevation greater than 2 millimeters in adjacent, no, so next to each other, precordial. Precordial means chest, the chest leads. So let's look at V1 and V2. So we have some ST elevation here, greater than 2 millimeters in adjacent precordial leads. Okay, we might also have some features of left bundle branch block. Um, might also have some features of left bundle branch block as well. And also remember that T-wave inversion. Okay, so we need to talk about a posterior MI. So we're going to have some ST depression in leads V1 to V3, which have an anterior, they look at the front of the heart. So because this is a posterior MI, there's going to be ST depression in V1 to V3 rather than ST elevation. If the precordial leads were placed on the back and therefore looking at the posterior, the back of the heart, there'd be elevation, but because they're placed on the front, it's ST depression. This is, this very, 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 very commonly comes up in exams. It's a really good thing to be aware of. Okay. So patients present with ST depression in V1 to V3, and they can also have a dominant R wave in V1. All right, so we need to, well, the ECG is such a useful tool in helping us determine where a coronary artery obstruction could be. So if it's in leads 2, 3 and AVF, this could be in the inferior region, this purple region here. V1 and V2, the anteroseptal region, this orange region here. V3 and V4, the anterior region. And then V5, V6, 1 and AVL, the anterolateral region. I think this is such a great diagram for helping you to understand that. It's really helped me get my head around this, get my head around it. So we've already mentioned this in the angina video about the ACS, acute coronary syndrome, common management. Patient wants to be admitted, 300 milligrams of aspirin stat, oxygen if they're saturated in less than 94%. So don't just be handing out oxygen to anyone if they're, only if they're desaturating. Morphine for severe pain. You could try them with 10 milligrams maximum. They might have some paracetamol, IV as well. And then just be careful of sublingual or IV nitrates, when the blood pressure's low. So if someone's had an MI, we have to, take into account different aspects of the management. So we have lifestyle modification, pharmacological management, and surgery. So let's talk about lifestyle modification first. So, after they spent roughly 3 to 5 days in hospital, we want to advise them about how to control their diabetes, how to improve their glycemic control if they have diabetes, advise smoking cessation, weight loss, and diet modification. You might refer them for some cardiac rehabilitation, an external site where they might do some progressive exercise regimes, group work and education. Education is very, very important. The more the patient understands about their condition, the better they'll be able to manage it themselves. And then typically have a 2-month leave from work. And when they come back to work, they might, consider a different role if they need to. This can all be arranged. And the GP can help support them with that. So we typically have 4 weeks, no driving or sexual intercourse. We don't want to, cause another MI. And then a lot of patients can have psychological problems such as depression. So it's important that you offer counselling, and we offer this biopsychosocial approach to care. Very, very, very important. I just want to mention as well that cardiovascular exercise helps to create new anastomosis, or new connections of blood vessels on the heart, improving cardiac collateral flow. But exercise is so, so important. And, if you have a um, if you have cardiovascular exercise routine, which is approved by the doctor, that it's a 5-time reduction in all cause mortality. So there's no drug in the world what can do that. So exercise is so important. Can't stress it enough. And then we've got pharmacological. So after they've had an MI, we won't have 75 milligrams of aspirin daily, plus a second antiplatelet medication. This could be clopidogrel, prasugrel, or ticagrelor. Um, and these are all anticoagulants, which help to disperse the clots. We have some beta blockers, so for example, bisoprolol, an ACE inhibitor, for example, lisinopril, GTN sprays, and a statin. So statins help to reduce the levels of bad cholesterol, the levels of LDL. Okay. And we mentioned that beta blockers prevent arrhythmias, and statins also help to stabilize plaques. And then lastly, we have surgery. So coronary angiography helps to view it basically allows you to view the vessels and the pattern of the vessels on the heart. Percutaneous coronary intervention, which we're going to talk about in more detail, and then coronary artery bypass grafts, which we're also going to talk about later in the video. So let's talk about NSTEMI in the acute management. So firstly, if there's a low bleeding risk or they're not offered angiography, you want to start them on fondaparinib, which is a synthetic low molecular weight heparin. If there's high bleeding risk and they're offered angiography, or there's an increased plasma creatinine, which could indicate some kidney problems, we want to use unfractionated heparin. It's much kinder to the kidneys. Then we want to calculate the Gray score. So the Gray score is the global registry of acute coronary events, and it's a risk assessment to determine if a patient needs coronary angiography, plus or minus PCI. Gray score is greater than 3, or they've got low blood pressure or ischemia following admission. Or there's essentially 2 different things what happens depending on what the Gray score is, or if they have these other features. So like we said, if the Gray score is greater than 3, they have low blood pressure or ischemia, ongoing ischemia. They can have PCI, so you need to give further unfractionated heparin, aspirin, and also a second antiplatelet, which we mentioned could be clopidogrel, prasugrel, or ticagrelor. So if the Gray score is less than 3%, so most patients would be considered for thrombolysis. To look for any relative or absolute contraindications, make sure there isn't any, or they might have some more conservative therapy, which would include aspirin and a second antiplatelet. If there's a high bleeding risk, you probably use clopidogrel, and if there's a low bleeding risk, they're more likely to use ticagrelor. Okay. And if thrombolysis is not effective, the patient can be referred for PCI. So let's talk about the acute management of a STEMI. So if they're 12 hours from the symptom onset and PCI cannot be delivered within 2 hours, consider thrombolysis. So 12 hours from symptom onset and they can't do PCI within 2 hours, you want to consider thrombolysis, the clot busting method. And then what you want to do is you want to check 60 to 90 minutes later if there's been resolution of the ST changes on the ECG. And depending on what we do next is determined by whether we still have these ST changes or not. So if we have resolution of the ST changes, they can have aftercare on the coronary care unit, and they'll be closely monitored. But if the ST changes are still present, we want to refer them for PCI, and that would be the right thing to do. And when we do so, Before the procedure, you want aspirin stat dose 300 milligrams of clopidogrel, um, uh, 600 milligrams, or prasugrel 60 milligrams, or ticagrelor 180 milligrams, plus some suitable analgesia. During PCI, if they insert the cardiac catheter via the radial artery, we want to also use some unfractionated heparin and another anticoagulant called abciximab. If there's femoral access, there's an anticoagulant called bivalirudin, and you can also use abciximab too. Okay, and if the symptoms last, so they present within 12 hours basically, they can also have PCI. It's ideal if the PCI is done within 2 hours of the symptom onset. And then what they essentially do during PCI is they can aspirate the thrombus, so remove the clot, and then they can inflate a balloon and then place stents. So stents are like little meshes which help to keep the vessels patent. And then also there'd be aftercare on the coronary care unit. Okay, so let's talk about fibrinolysis or thrombolysis. These two words are interchangeable. This slide's mainly for your own reference. We can look at the relative contraindications and the absolute contraindications. I'm sure you can go through these. And thrombolysis is most effective within 6 hours of symptom onset. And sometimes there's things called reperfusion arrhythmias, which can occur within 2 hours. Within 2 hours of after thrombolysis has been administered, and it typically tends to be ventricular tachycardias and ectopics. And yeah, some examples are streptokinase, alteplase, retaplase, and tecmetaplase. So the one used in my trust currently is alteplase. So I'll have to check that. Right. So let's talk about PCI, so percutaneous via the skin into one of the arteries, coronary intervention. Okay. So we need some arterial access. So that can be radial or femoral, which allows catheter intubation and assessment using video fluoroscopy. So we can look in real time at the coronary arteries, and there can also be further assessment using intravenous ultrasound, which can actually look at the a cross section of the artery. And PCI, the different options, there can be plain balloon angioplasty. So a balloon can inflate. A balloon inflates, helping to increase the diameter and reduce that stenosis. Although the balloon can recoil and you can have restenosis. There are also drug-eluting stents. Drug-eluting stents, and the drugs released by the stents help to reduce some of that smooth muscle proliferation, which we know as part of the atherosclerotic process in terms of the plaque formation. And pretty much stenosis within pretty much any coronary vessel can be stented. But if it can't, then we can look at other surgical options such as a coronary artery bypass graft. And then this table here which talks about some of the lesions favourable for PCI, so lesions with the discrete, proximal, non-calcified, unoccluded, and away from smaller side branches, and lesions unfavourable for PCI, so grafts, bifurcation, so branches of vessels, if they're calcified, and they include the smaller side branches. All right, okay. So let's talk about coronary artery bypass graft, or CABG. I was lucky enough to see some of these procedures during my elective in Australia. And these procedures can be uh, off pump or on pump. So on pump means that they use a cardiopulmonary, they use a bypass machine essentially and stop the heart to do the graft. So the machine essentially acts as an artificial heart um, to pump the patient's blood, or if it's off pump, the heart's still beating. So let's just look at some of the indications. So if there's left main coronary artery stenosis, and this stenosis is tends to be severe, or if there's triple vessel disease, including the RCA, LAD, and the left circumflex artery, or if there's severe pain post PCI, they might consider doing a CABG. Okay, we've already mentioned that on pump means using the cardiac bypass machine, and I'm actually learnt this myself, that they can use the internal mammary artery to bypass the occlusion, or they can use a saphenous vein graft. I think it's so interesting how they manage to do that. Yeah, very, very impressive. Okay, so let's talk about some complications of MI. So again, I always like to look at the pathophysiology, and then the mechanism, and then how that leads to the complications. So let's talk about so what we have here, we have reduced contractility due to myocardial necrosis, and then irritability of the tissue next to the infarcted tissue. So we'll talk about this one first. So this can lead to ectopic beats and re-entrance circuits. When I do a video on arrhythmias, we'll talk about this in more detail. All right, so we'll go back to this one actually. So when you have reduced contractility due to myocardial necrosis, there's blood stasis, and you can have a mural thrombus formation. So a mural thrombus is a blood clot, but just within one of the heart chambers. And then this thrombus can embolize, so it can go to another location. So the cerebral arteries causing a stroke. The mesenteric arteries, it could be the SMA, the IMA, causing mesenteric ischemia. It could end up in one of the large arteries of the limbs, causing acute limb ischemia, or one of the renal arteries causing a renal infarction. And then because we have reduced contractility, we have pump dysfunction. So the pump is dysfunctional. So therefore we have reduced cardiac output and systemic perfusion. And this can lead to cardiogenic shock, which in turn leads to systemic organ failure, because the organs aren't receiving the blood containing the oxygen that they need to function. And this tends to be with quite like an acute drop in cardiac output. And then we have the other option. The other thing what can happen is congestive heart failure. And as a result of congestive heart failure, the atria distend, and this can disturb the electrical works of the atria, causing them to fibrillate. So one of the important complications is atrial fibrillation. Next, we're going to look at the irritability of the tissue adjacent to the infarct. And like I said, this can cause ectopic beats and re-entrance circuits, and this causes arrhythmias, so abnormal heart rhythms. And the two main ones are ventricular tachycardia and ventricular fibrillation. And I will do another video on these two arrhythmias, how they present on the ECG, and their management. It's worth mentioning at this point, VTAC and VFib are shockable rhythms. So you can apply the defibrillator pads to the patient's chest, and they are shockable rhythms compared to something like pulseless electrical activity or asystole, which are non-shockable rhythms. Okay, and then other complications are based on necrosis of the ventricular wall. So you can have ischemic tissue disrupting the bundle of His, leading to bradyarrhythmias. So transmural across all the layers. You have this necrosis of the intraventricular septum, leading to an acquired ventricular septal defect, and that can cause a pansystolic or holosystolic murmur. Papillary muscle rupture and necrosis and rupture, and then this leaves the valve leaflets unsupported, into acute mitral regurgitation. I mentioned the flash pulmonary edema earlier. And then all three of these, so the bradyarrhythmias, acquired VSD, and the acute mitral regurg, all lead to pump dysfunction. And if you remember from the previous slide, pump dysfunction can lead to cardiogenic shock and or congestive heart failure. Cardiogenic shock leads to systemic organ dysfunction because they're not being perfused, the organs aren't being perfused, and then the congestive heart failure leads to atrial fibrillation. Okay, so this is kind of how it all ties in. You can also have non-septal wall necrosis, so further down the intraventricular septum, reduced ventricular wall strength. The ventricular wall can thin but not rupture, and this leads to an aneurysm, so a ballooning of the ventricular wall. But if there's inadequate scarring, the ventricular free wall can rupture, and this can lead to something called cardiac tamponade. And that's essentially where we have lots of fluid and blood within the pericardial sac. And if you were to examine a patient, they're likely to have muffled heart sounds, an elevated JVP, and they'll also have low blood pressure. Okay, and then the necrosis of the ventricular wall, you can get these infiltrates irritating the pericardium, leading to pericarditis, inflammation of the pericardium, and fluid accumulation in the pericardial sac. And this can also progress to cardiac tamponade, which is an emergency which needs immediate attention. Okay, and I just thought I'd mention at the end, so complete heart block can be caused by occlusion of the right coronary artery, because the right coronary artery typically has an AV nodal branch. Options you might look at, so medications such as atropine. You might consider PCI to remove the obstruction, or temporary wire pacing. There are lots of different options. There's single, dual, or biventricular pacing. And then just a complication, what I wanted to mention as well, which isn't already on here, is something called Dressler syndrome, which is autoimmune pericarditis, and this can occur roughly 2 weeks post-MI, and the patient might have a high ESR, anemia, pleural effusion, and also anti-cardiac muscle antibodies, and this can sometimes be confused as the patient having a second MI. And with all that being said, that brings me to the end of the video. It's been very enjoyable for me to talk through. It's a topic which I find very, very interesting, and yeah, I look forward to doing the next one. I think the next video I'm going to talk about heart failure, and yeah, hopefully that was really useful. And don't forget to check out my website, and also have a look at my PayHip, where you can access my personal notes. Yeah, which you might find useful. But yeah, look forward to next time, and yeah, take care.